speaker, who is the Director of Critical Care, Narayana Super Specialty Hospital, Gurgaon. Achievements are General Secretary, ICCCM 2024 and 25, North Zone Representative, National Executive, ICCCM 2022-24, Chairman, ISCCM, Gurgaon Branch 22-24, and Coordinator Research Committee, ISCCM 23-24.
Thank you, Chairpersons, for the introduction, and I would also thank Dr. Maharaj for having me here. So I have been given the talk of how do you ventilate your post cardiac arrest patients. Is there anything different that you do for these special subset or a difficult subset of patients? Because as such, once a patient has a cardiac arrest, you resuscitate. There are other factors that take in place. What is the hemodynamics? What are the issues that cause cardiac arrest? And among them, how do you ventilate them correctly? So the objectives are very, very simple. You want an optimal gas exchange. You want to limit any ventilatory associated lung injury. Then you want to avoid the complications which can develop because of these ventilatory strategies. You want to limit both hypoxemia and hyperoxemia and look at normocapnia. So very simple ventilatory strategies that you do for all patients. Now this was a very recent article where they looked at what should be the 10 rules of optimizing ventilatory strategies and what should be your targets in post-cardiac arrest patients. So they first looked at the tidal volume. What should be the tidal volume in this particular subset? And we know that it is a very, very important key parameter when it comes to lung protective ventilation. We are aware of our ARDS net protocol where it says 6 to 8 ml kg of predicted body weight. The association of keeping low or ultra low tidal volume along with a cardiac arrest population, we don't have that data. That subgroup analysis is not there. We don't have those numbers in most of the RCTs. So you actually don't know how good or bad is that ventilatory strategy to be done. So in 2021, the European Resuscitation Council and the ESICM, they came up with post-resuscitation care guidelines. They looked at this concept, and what they found was, this is an important thing. You need to maintain your PO2, SO2, PCO2, and important thing is tidal volume. The tidal volume should be 6 to 8 ml per kg. And again, it is more or less similar to what your ARDS ventilation stands for. Then there was one more study where they looked at what is the neurological outcome in patients who are ventilated with low tidal volume after a cardiac arrest. So they wanted to study this part on various techniques. When they looked at propensity score or multivariate regression or even inverse probability of treatment, in every angle they found that low tidal volume strategy had a favorable neurological outcome. It was not only the mortality benefit, but the neurological outcome was much better in patients who underwent low tidal volume strategy. The secondary outcomes were also much better in these patients who were ventilated with low tidal volume, and when we look at ventilator free days, so all organ support free days we are talking about, the shock free, renal failure free, hepatic failure free, coagulation free, ICU length of stay and hospital length of stay, they were all shorter in patients who underwent low tidal volume strategy. So now looking at the data that we have and what is the present role is, in all post-cardiac arrest patients, the tidal volume should be set between 6 to 8 ml per kg, either in a volume control or a pressure control ventilation, but always keep in mind other factors like what is your P plat, what is your driving pressure, what is the P and the mechanical power, and I will take you through all these variables as well. So 6 to 8 ml per kg should be your first setting to start with. Then let us talk about plateau pressure. Now we have learned from again ARDS that we want a plateau pressure cutoff of 30. We don't want to cross that 30. We are aware that it causes ventilatory induced lung injury. But in post-cardiac arrest patient, this number varies. Now if you are looking at this number of 20 in patients without ARDS, so they looked at if you are keeping a plateau pressure of 20 or less than 20 without ARDS, it is recommended. Now, the TTM2 trial, when they looked at ventilative strategies in the first 72 hours, they found that patients who had a plateau pressure of less than 20 had more survival as compared to patients who had less than 25 or let's say even less than 30. So your cutoff was still there, but still there was a huge mortality difference when this plateau pressure was brought down even further. And on the basis of this, the latest recommendations are that the P-plat should be aimed to reduce the ventilatory lung strategy, and the number that they are looking at is equal to or less than 20. They are not talking about less than 30. So you break down that number if possible by your ventilatory strategies and you will have a mortality benefit, specifically when we are talking about a post-cardiac arrest scenario. PEEP. Now PEEP plays a huge role when it comes to mechanical ventilation. We all agree that if you are keeping a very low PEEP or let's say a zero PEEP, you will have atelectasis, you will have gas exchange issues. Similarly, if you are giving higher PEEP, then the risk of intracranial hypertension is there. But there is no randomized trial about what is the optimal PEEP in post-cardiac arrest scenario, and we try to extrapolate data from patients who did not have ARDS. We try to put that data and we say fine, we'll ventilate our post-cardiac arrest patients in that manner. In the same TTM2 trial, they looked at what should be your ideal PEEP setting, and they found that if your PEEP settings are between 5 to 7, the mortality was better as compared to patients who had a higher PEEP, and that higher PEEP that they were looking at was around 10 to 15. So a PEEP level of 5 to 7 in post-cardiac arrest patients should be preferred as compared to higher PEEP, and this is what they suggested, that patients of post-cardiac arrest should be ventilated ideally at a PEEP of 5% and target your saturation to 92 to 94%. Don't try to look at what should be the 100% and how do I get 100% saturation of these patients. So 5 to 7 PEEP is what you look at. Then driving pressure. Now we all ventilate our patients based on the driving pressure, and we understand that this is the distending pressure of the lungs, and this is the result of P-plat minus PEEP. So you wanted a lower P-plat, you wanted a lower PEEP, and we say a driving pressure of around 15 is more or less the ideal way to ventilate these patients, because you don't want to put stress to your alveoli and you don't want an alveolar trauma happening because of these ventilation. So in this paper, where they looked at what should be your ventilatory variables and mechanical power in ARDS patients, they found that as you keep on increasing your driving pressure, there is an injury to the lung, there is a ventilatory associated lung injury, and a driving pressure of less than 15, even less than 12 was associated with much better outcome if you are talking about only post-cardiac arrest subset. And again, the TTM2 trial, when they looked at this strategy, they said that the lower the driving pressure, lower is the mortality, and they concluded that keep a driving pressure of less than 13. We try to keep a driving pressure of around 15 when we are ventilating our ARDS patients, but when it comes to post-cardiac arrest scenario without ARDS, try to keep a driving pressure of even lesser, which is around 12 or so. Then the respiratory rate. Now we all try to keep a respiratory rate so that we adjust our arterial blood gas. We want to ventilate them at ultra low time volume strategy. We adjust our respiratory rate so that we have a pH of more than 7.2. But we also know that by causing hypocapnia or hypercapnia, they both have certain central venous system effects. We don't want vasoconstriction and we don't want vasodilation, specifically in a post-cardiac arrest scenario. So the guidelines say that there is insufficient data as to suggest should we actually ventilate these patients in mild hypercapnia. There were earlier trials which said if you are giving mild hypercapnia post-cardiac arrest, they were considered to be better neuroprotective in nature. But now there is no data to suggest that should we target mild hypercapnia as compared to normocapnia when it comes to patients who have an ROSC post-cardiac arrest, and they said it's a very low evidence on how to ventilate these patients, and so on the basis of that, try to keep your respiratory rate between 8 to 16 and achieve normocapnia as soon as possible rather than ventilating them to keep mild hypercapnia. Mechanical power. Now this is again an important variable. We know that we multiply our tidal volume and divide this by the predicted body weight into respiratory rate, but this is an important thing where it is considered what should be your tidal volume, what should be your respiratory rate, because this is the power that the lung is getting generating for ventilation, and this is the power which your alveoli is getting transmitted. So this accounts for several parameters, and for this reason now we try to ventilate our patients looking what is the mechanical power, what is the driving pressure that this patient is generating to get ventilated. So there were two observational cohorts, and they looked at what is the mechanical power of ventilation and is it associated with any mortality harm or mortality benefit in critically ill patients, and they found was as your mechanical power was increasing, the mortality was increasing, and the lower the mechanical power, the lower is the mortality. And when they concluded that patients who receive invasive ventilation for at least 48 hours, higher mechanical power is independently associated with high mortality and very poor patient-centered outcomes. And on the basis of this, the recommendation says at least try to target a mechanical power of 17 joules per minute or even lower, along with the lower driving pressure to ventilate these post-cardiac arrest patients. Then comes about normoxia. What should be your oxygen target? Now, we all know that oxygen is a key parameter. We try to keep it as high as normal, at least in the initial post-cardiac arrest scenario, but it also increases the risk of reperfusion injury and other oxidative stress which can contribute to brain damage and neuronal damage. Similarly, hypoxemia in the post-cardiac arrest scenario, it causes it affects the cerebral aerobic metabolism, and it also leads to neuronal injury and death if it is not restored timely. Higher oxygenation given, as was told by Dr. Srinivas, that Professor Shoemaker tried superoxygen therapy and looked at will it improve the outcome. Unluckily, that did not happen. So when you look at effect of hyperoxia or mortality in critically ill patients, it was found that it did not have a positive outcome. Rather, it did not change any outcome when you look at the overall scenario, and it was eventually leading to a higher mortality. So you don't look at hyperoxia when you are talking about critically ill patients, and same stands true for your post-cardiac arrest patient. Now, this was another article based on TTM2 where they looked at what should be your oxygen target and 6-month outcome, keeping that target in place after a post-cardiac arrest scenario. And what they defined looking at that entire cohort was, if you want to define hypoxia in a post-cardiac arrest scenario, the number was 69, PO2 of 69 and below. And if you have to define hyperoxia, it was 195 and above. And so they said that these are the best cutoffs that you can put, and on the basis of this, your oxygen targets should be fitted between 69 and 195. It should be your oxygen target to avoid any effects of hypoxia or hyperoxia. And so the guidelines say, now this is one big trial which is running on, the data is not out. Again, they are looking at what should be the oxygen target in post-cardiac arrest scenario, the MEGA-ROX trial. The data probably will be out by the end of this year. Till that time, try to target between 70 to 110. These are the guidelines which say even after looking at the TTM2 trial where they said 70 to 195, but still they feel 70 to 110 is an optimal oxygen PO2 ratio that you should maintain. For normocapnia, we know that hypercapnia and hypocapnia both are detrimental, and we don't want any anaerobic metabolism to go on for these patients. And so when you look at what should be the carbon dioxide dynamics in relation to the neurological outcome in out of hospital cardiac arrest scenario, they found that if you are looking at PaCO2 levels over time, they do not affect the outcomes, neurological outcomes of these patients. So again, keeping them normocapnia or mild hypercapnia did not affect much. And very recent trial 2022 NEGM where they looked at should mild hypercapnia always be preferred, because earlier articles they said mild hypercapnia is neuroprotective in nature, but they found that it did not change much of neurological outcome when you are looking at all subsets, younger or elderly patients, what was the time for ROSC, what was the initial rhythm, and was this patient in shock or not. So it did not affect any better neurological outcome, and they concluded that targeting mild hypercapnia did not improve the neurological outcome at 6 months. And similar is the guidelines from the Neurocritical Care Society, where they look at critical care management of patients after cardiac arrest. They said that you can still look at a higher PCO2 provided your pH is above 7.2. If your pH is going below 7.2, then you can look at a slightly lower PCO2. So the target was pH rather than PCO2 in terms of neuroprotective in nature, and this is what the guidelines also say. Temperature, we all know that hyperthermia increases the CMRO2, or the metabolic rate of the oxygen of the brain, and so we want to keep these patients normothermic, and on the basis of this temperature there are many studies, the TPM and other studies are there. So they say that always try to keep these patients at 37.7 or even below than that after post-cardiac arrest, and because your arterial blood gases are based on your temperature, and we try to normalize our arterial blood gases based on the temperature. The last part is the hemodynamics. Yes, ventilation is associated with hemodynamic instability, so give your fluids, administer vasopressors, try to keep a normal dynamic status in these patients, and avoid ventilatory associated hemodynamic instability. In this recent article where they looked at should we try to keep a higher blood pressure or a lower blood pressure, and when we say a higher blood pressure, they were targeting about 100 mmHg of mean. They found that there is no difference in the neurological outcome or mortality whether this was a higher blood pressure or the lower blood pressure, and they said 77 mmHg with 63 mmHg did not make much of a difference. And so post cardiac arrest syndrome patients should be strictly monitored for any detrimental respiratory and cardiovascular interactions which will take place. So these are the 10 basic simple rules. Try to ventilate these patients at 6 to 8 mm per kg of predicted body weight. Keep your P flat as less than 20, P 5 to 7. Target your driving pressure of less than 30, mechanical power of less than 17 joule. Keep your respiratory rate as physiological as possible. PaO2, don't go for hyperoxia. PaO2 of 70 to 100 and a PCO2 again normocapnia is what we are looking at. Avoid any hypothermia, and the mean arterial pressure should be individualized. You cannot have one solitary number to target when you are ventilating these patients. So ventilated management post cardiac arrest follows the simple rule, just little tweaking of the numbers is there. And yes, we should ventilate them with lung protective ventilation strategy. That's the normal norm, whether your patient has ARDS or the patient does not have ARDS. Follow normoxia, follow normocapnia in these patients. Thank you so much.
Thank you, sir.